Once again, this is Dr. Larry Altschul speaking to you from Good Samaritan Hospital University virtual classes on heart health. In the past 10 to 20 years, there have been tremendous strides in cardiology, and there would definitely be a lot to talk about in terms of education. But in the limited time we have, I chose to kick this off with a presentation on coronary artery disease, heart attacks, things that you can do, and what can we do. As most people know, heart disease is responsible for nearly 40% of all the deaths in this country every year. This totally eclipses all other causes of death, including all of the cancers added together: diabetes, strokes, lung disease, accidents, everything. In this country alone, there will be 1.2 million heart attacks this year and every year. Out of that, 500,000 people will die. Now, to put things in perspective, in this past fiscal year, February to February, there are now nearly 500,000 deaths from COVID. Everybody has been shocked, both worldwide and this country, about the high mortality. Yet this number, 500,000, is the same number of people that die every single year in this country from heart disease. Now, before we talk about management or what you can do, I'd like to review a little bit about the pathophysiology. Depending on your risk factors, and beginning relatively early in life, cholesterol, in particular the bad cholesterol, LDL cholesterol, begins to accumulate in the walls of the artery. Now, this can start at a very young age. In fact, back in the 50s, there were reports coming out of the MASH units in Korea during the war, where surgeons were there were horrified at the number of men between the ages of 18 and 25 who came into those MASH hospitals with major chest wounds, that they were able to visualize how many of them already had the beginnings of coronary plaque or arterial plaque in their arteries, so-called fatty streaking. Again, depending on your risk factors and how you manage your life, that cholesterol will continue to accumulate over the years in the wall. And as it does so, you can see that it encroaches on the lumen, or the diameter of the coronary artery that's feeding the heart muscle. In general, it is felt that symptoms of progressive coronary artery disease don't start until an artery is about 70% narrowed, but that is highly variable. Once you've reached that point of narrowing, there begins a time where you may develop warning signs or symptoms, especially during exertion or exercise. Now, those symptoms are also very variable, but the most common symptom, as you know, is chest pain. And the most common description of the chest pain is one of tightness, heaviness, or a weight on the chest that's generally precipitated by activity that you used to be able to do without a problem. And then with rest, it goes away. Now, not everybody has chest pain. Some people have shortness of breath with activity that they never had shortness of breath before. Some people just have lightheadedness or dizziness with exercise as their only warning sign, or excessive fatigue. Sometimes they have pain, but it's not in their chest. It's in other parts of the body, like the left arm, the neck, the jaw, the gums, or in the stomach area as well. And you can see why it can be difficult for physician and patient sometimes to interpret their symptomatology. As we go along, the cause of most acute heart attacks is not just that the artery slowly narrows until it becomes 100% blocked. And generally, the mechanism is that that plaque, the surface lining of that plaque, begins to erode over time, crack or rupture. Once that cholesterol pool is exposed to the cellular elements in the bloodstream, a clot can form. Now, clotting is a very complex process in the body, and there are many steps. But the first step of clotting is that a blood cell called the platelet sticks to that eroded area. And when it sticks there, it becomes activated. And when it's activated, it secretes substances that attract other platelets and begin the cascade of clotting that will result in a scab-like look on that lesion. Now, clotting is obviously very important in the body. You surely want it on your skin if you cut yourself to stop the bleeding. But inside the artery, a clot, even a small one, can totally block that artery because there's very little space. And that could be an abrupt event, which suddenly increases symptoms of exertional chest pain or shortness of breath, or a more severe set of symptoms that doesn't go away even with rest. Now, this is the microscopic view of several coronary arteries in patients that have had coronary artery disease. You can see that the plaque or the lesion in the coronary artery is made up of two things: a big thick area of soft cholesterol, and associated with that is the precipitation of hard calcium. So calcium and cholesterol make up most blockages in these arteries. On the left, that artery is about 50% narrowed. Generally, it is felt that symptoms of blockages or coronary artery disease don't begin, as I said before, until the artery is about 70%. And it is likely that this artery did not result in any symptomatology in this patient. On the right, that coronary artery is about 75–80% blocked. And it is highly probable that this patient did develop new symptomatology aggravated by exertion, relieved by rest. But again, that's not a guarantee. There are many people out there that have no symptoms at all as these arteries narrow down. Now, this is an autopsy specimen of somebody that died of diffuse coronary artery disease. And you can see that if the wall of that artery is pinched with a plier or a tool that they use in the OR, you can see that the makeup of that substance in the arterial wall resembles very much that hunk of cheese on the slice of pizza you ate last week. This is the cross-section of an artery in somebody, of a 48-year-old male, in fact, that developed sudden onset chest pain, called an ambulance, but did not make it to the hospital. They had an autopsy, and this is the cross-section of a major coronary artery, probably the most important one in the body. And you could see here that the artery was about 75% blocked. But then where that square is, that rectangle, that's where the artery plaque eroded. And on top of that, a thrombus or clot formed rapidly that totally occluded that artery. The entire area fed by that artery began a process of dying off after this happened. And since this was the main coronary artery, feeding at least 40% of the heart muscle, the person did not even survive getting to the hospital. Now, when we think about treatment of coronary artery disease, it is really involves three tiers. It's not just about treating the heart attack when somebody comes. We as cardiologists are focused on prevention, which is very important, addressing all the risk factors, hopefully to reduce the development or the amount of plaque that will form in arteries as you get older, reduce the chance for plaque to rupture, reduce the chance that plaque will get a clot on it. And then when the person has a heart attack, there are things that we can do in the hospital, both advanced medications and advanced interventions that we can try to get that artery open that's been totally blocked and get it open fast. Now, if you survive the heart attack, there's then the recovery period. What do we do after? Well, clearly, the same things that are involved in prevention will apply to very aggressive events in terms of dealing with risk factors. But depending on the amount of heart muscle that is lost, one may develop signs and symptoms of progressive congestive heart failure. The pump becomes weak, and the output of the heart decreases, limiting the exercise and causing a poorer quality of life. It has been well recognized through studies that if the heart muscle falls below a certain level of weakness, which we refer to as the ejection fraction in our testing, the lifespan can be shortened. And again, we have tools to prolong life in this setting. So let's first discuss our risk factors, which is clearly the focus here. There are 7 highly accepted risk factors that have clearly been documented through multiple studies to be associated with early coronary artery disease and early heart death. We start with family history, your genes. Due to the advent of the Human Genome Project years ago, we are now discovering genes associated with certain diseases. To date, there are at least 8 to 10 genes that have been identified that if you have them, there'll be a higher likelihood you'll develop coronary artery disease and a heart attack because they result in accelerated deposition of cholesterol in the arterial wall, and this is independent of all the other risk factors, independent of your level of cholesterol. Then, of course, there's smoking. You all know that smoking increases the risk of heart disease. There is something about the toxins in burning tobacco that when inhaled, get into the bloodstream, react with the lining of your arteries so they attract cholesterol like a magnet. Obviously, the higher your cholesterol, in particular the bad cholesterol, LDL, the higher chance it will precipitate in the arterial walls over time. Diabetes is a major risk factor. Again, without going into the specifics, because we don't have the time, there's something about disordered carbohydrate metabolism in the body that will lead to accelerated blockages in all the arteries in your body to various degrees, whether that's to the heart, leading to heart attacks, whether that's to the brain, leading to stroke, whether that's to the eyes, leading to visual problems, to the kidneys for kidney failure, to the legs for gangrene and amputations. So diabetes is a problem that must be addressed and handled appropriately if we are to reduce the risk of some of these severe complications over time. Obesity has, without a doubt, in every study, been linked to coronary artery disease as well as to multiple other serious life-threatening problems. Sedentary lifestyle. There have been umpteen studies where they've added an arm of regular exercise to everything else they do for whatever disease process they're looking at, and in every case, the group that exercises regularly, aerobically, throughout the week, year after year, has a definite reduced mortality, longer lifespan, but on top of that, a better quality of life too. You not only live longer, you feel better. So let's look at smoking. Smoking is the single most preventable cause of heart death, of death. Now you know that smoking causes lung cancer, and obviously everybody can fear that. But in fact, if we took all the people who died because they were smokers, by far and away most die of a heart attack. People who smoke are at least 6 times more likely to develop a heart attack over time. Obviously, the higher your cholesterol, the higher the chance of developing coronary artery disease, such that levels beyond 225 to 250 increase the incidence of cardiovascular disease exponentially. Interestingly, studies have clearly shown that cholesterol-lowering drugs like statins, you may all have heard the term statins, that if you take people with high cholesterol and follow them through their life, if you add a statin to their regimen, such as Lipitor, Crestor, there are many of them out there, the likelihood that they will die from a heart attack or even a stroke drops precipitously right away over the first few months, but clearly over the years that they take this medication. Obesity, as I said, has been associated with early death, and it's for many reasons. There are many problems that obesity will increase the incidence of, but heart disease is one of them. And studies have shown that if you drop your weight closer to levels which are appropriate for your height, such on the bottom line, that's the BMI or body mass index, basically weight divided by your height in meters, the mortality drops precipitously again. This also applies to exercise. If you avoid exercise and basically have a sedentary lifestyle, especially if you have other risk factors, the likelihood that you will have an early loss of life from a cardiovascular event increases significantly. Conversely, people who now start an exercise program, even later in life, even after their heart attacks, if they start an exercise program, the likelihood that they will return for a second or third event or more stents or bypass also drops significantly over time. Now, obesity increases the risk of coronary artery disease, but it also increases the risk of several other very serious problems, including diabetes and hypertension, high blood pressure. Both of those, in and of themselves, are risk factors for coronary artery disease. Now, all of your risk factors are additive. The more you have, the higher the chance you will lose your life earlier than you should have from a cardiovascular event. And regardless what risk factor you're dealing with, if you add blood pressure and control blood pressure within that risk profile, you can drop your likelihood of getting a coronary event. As you can see, as each of those 4 bars represent a higher systolic or top number blood pressure in patients with those risk factors. Now, this is just a slide for reference. I'm not going to go over it. But diet plays a big role in the development of coronary artery disease. Essentially, and maybe simplifying it a bit, diet should be low in trans fats and saturated fatty acids. And this is a chart that you could refer to later on the website or on Facebook, showing the types of food, the types of fats they have, and the effect that they might have on developing coronary artery disease or losing your life from a coronary event. Genetics, as I said, also plays a role. The more you have in the family, the more first-degree relatives that have had a heart attack or have had stents or bypass, the more of them that you have in your family, the higher the chance the same thing will happen to you. Now, first-degree relatives are defined as mother, father, brothers, and sisters. Those are your first-degree relatives. Now, unfortunately, as of this date, there's nothing we can do about your genes. But that may change in the future and is likely to change, I will say. I will guess that in 10 to 15 years, the treatment for coronary artery disease and many disease processes will change dramatically and be directed towards gene modification. You're finding the genes of what they do or what they do wrong, and treatments will be developed to either remove the genes, add genes, or just treat the proteins that are made or not made by these genes that result in accelerated atherosclerosis. Now, what if you have no symptoms? How do you know if you're really at risk? Well, of course, you have risk factors, and that can give you a clue. But how do you know now whether that affected you? Luckily, we have new testing equipment, which is highly safe and easy to do, quick, done in seconds, as a matter of fact, and that is coronary calcium scoring, which is a CAT scan machine with a specialized program that measures the amount of calcium in your coronary arteries. Now, this has been shown to directly correlate with the likelihood of developing future coronary events. If we look here in these 4 boxes, in the upper left, we have the chance of getting or dying from a cardiovascular event if your calcium score is 0, no calcium seen in your coronary arteries. And you can see that the likelihood of having a coronary event by year 10 to 12 after, let's say, age 55 when the test is done, the likelihood of that happening is very low, 2 to 3%. If you have a little calcium in your arteries, calcium score of 1 to 100, the second box on the right, on the top, you see that there's a slightly higher chance of dying from a coronary event, maybe 5% over 10 years. If the calcium score is high, from 100 to 400, you can see the likelihood of dying or getting a coronary event or requiring intervention goes up to above 15% over the next 10 to 12 years, and that's the blue line. The one on the lower right is a calcium score in excess of 400. You have numbers in that range, the likelihood of getting a coronary event by years 10 or 12 after the index test will be as high as 20%. Interestingly, if you take a person, even if their cholesterol is entirely normal, if you put them on a statin, well, if you're in the upper left-hand corner, that'll have no effect because the cholesterols were normal. But as your calcium score rises, you see that the likelihood of developing coronary problems or dying from a heart attack, as in the bottom 2 squares, drops by at least 50% over time. And this is why we recommend statins to patients even if they have normal cholesterol, if their calcium score is high. And by statins, there are many of them out there. Again, you've heard of them: Lipitor, Crestor, Zocor, simvastatin, rosuvastatin. There are a whole bunch of them out there. But all the group equally will drop the chance of getting heart disease if you start taking it early when you find out you have coronary calcification. So when we approach the patient with coronary artery disease as cardiologists, yes, of course, we have wonderful medications that have been studied that clearly will reduce heart attacks and death and also help with your coronary risk factors in prevention. And we have, if the coronary artery disease evolves and becomes critically tight blockages in major vessels, we have interventions, stenting, bypass surgery, which I will get to in a moment. But by far and away, equally as important is the educated patient, the patient who knows their risk factors, knows what their chances are, and knows that if they remove that risk factor or lower that risk factor, will impact significantly on the prevention of a coronary event. So when it comes to risk factors, some of this is pretty obvious. The first thing would be lifestyle changes. Obviously, if you're smoking, you should stop. I mean, that's a no-brainer. And there are plenty of resources out there, websites, 1-800 numbers that you can actually call to get advice on how to do this. It could be cold turkey, it could be nicotine patches, there are pharmacological interventions, there's acupuncture, there's hypnosis, but there are plenty of ways that one can try to get off cigarette smoking if it is hard to do. Also, obviously, dieting. Not just to lose weight, but even if you have an appropriate weight, just eating the right kinds of foods. Again, low in saturated fats, low in trans fats. And exercise, I've mentioned many times already. Regular exercise will reduce the likelihood of getting a coronary event. And a lot of people are intimidated by exercise. They've sat around for many years, they're 62 years old, they don't exercise, they sit on the couch, they watch the news, they hardly move. And then we ask them to exercise. And they're intimidated by that because they're used to seeing exercise programs and people in gyms running away, getting sweaty, doing an hour and a half of exercise. They actually did studies on this. And it was shown that even a tiny amount of exercise, 5-10 minutes a day of something a little aerobic, 5 days a week, follow them out 10 years, improves their longevity, improves their quality of life, and reduces heart attacks. So even if you don't have equipment, walk up and down the stairs 3 times, back and forth, up and down, 5 minutes every day. Get a little short of breath. Remind your heart and your body that it is there to do some work. You know, our bodies go into a phase of decline after the age of 35. We can't help that. That's built into our genes. That is life. That is death. We can't control the ultimate endpoint. What we can control is the slope of that line as we deteriorate. It could be more gradual or start later. And not only that, you'll feel better living longer. And that has been proven. These are not just words. Obviously, your cholesterol. If you already have documented vascular disease of any kind, the goal is to get that bad cholesterol, the LDL cholesterol, below a level of 100. 130 is actually considered normal. But if you already have some early atherosclerosis or have had a coronary event, the goal, the target, is below 100. If you have coronary artery disease and diabetes, that's a 1-2 punch. Diabetes being a big risk factor, studies have shown that if we drive the cholesterol below, the LDL, below 70, the outcomes are even better than driving them below 100. So our target LDL for the diabetic patient who also has coronary artery disease is below 7. And I will go off the cuff now by saying that anyone with any kind of vascular disease or risk factors, the lower the LDL, the better. There is no such thing, nothing's been documented to be problematic if the LDL is quote-unquote too low. That hasn't been shown. That'd be a problem. Obviously, if you have diabetes, control of that diabetic problem is essential in your future management. And by control, we're talking about a serum A1C below 7.0. Now, if you're a diabetic, you know what that means. A1C is a blood test that really reflects your average diabetic control over the previous 3 months. So it gives sort of a range of where you've been. Normal is below 6, but below 7 is considered adequate diabetic control, and that is our target. Something very important. I've mentioned statins over and over. Probably one of the most important medications that have been developed over the past 25, 30 years. Unfortunately, there are a lot of patients, a lot of people that can't tolerate statins. About 10 to 20% of patients placed on a statin have to stop them due to a very unpleasant muscle ache. Now again, many do tolerate it, but there's a large number that don't. And that is the cornerstone of treatment for vascular disease. But luckily, there are new medications on the market now that are injectable. The two out there are Repatha and Praluent. Now, you may be afraid of injections, but in fact, it's a very tiny little needle, not every day. You know, diabetics take this little insulin needle every single day, sometimes multiple times a day. For this drug, you only have to give it to yourself twice a month. 1 day out of every 2 weeks of a tiny little pinch, and you're good. It comes very easily to administer, prepared. You just open the box. It's already organized in the syringe with a needle with the right amount. You make a little poke, push it in, take it out, discard it. Very simple to do. And studies have shown with these two drugs that the improved outcomes that we've seen with statins is reproduced. Luckily, these two drugs have very few side effects. Very few people have to stop them from any side effects. Hardly anyone gets any muscle aches. There may be a rare person, but most don't have any side effects at all. The only problem with these two drugs is that they're new. They're relatively new, which means they're expensive. Drug companies, though, many of them will approve these drugs in patients who can't tolerate statins. Why will they pay for them? Because they know that on the back end, they'll save money. By these patients, they're insured, they'll have less heart attacks, less hospitalizations. Let's talk about other medications that have been tried and proven to have a positive effect on longevity relative to coronary artery disease. You all know about aspirin. And I've talked about clotting as the cause of the actual heart attack. And the beginning of clotting being platelets, those cells in the blood that stick to that open wounded artery on the inside. The way aspirins work is they inhibit platelet aggregation or platelet stickiness, if you will. And by doing so, reduce the likelihood or the amount of thrombus or clot that will form in case you have blockages that get cracked or eroded. And the amount of aspirin that you need to do this is very low. Just 1 baby aspirin a day is all you need. Taking more aspirin doesn't increase the positive outcome. It only may increase the chance of getting stomach irritation. So we only prescribe 81 milligrams. That's all we need. Now, if you've had stents placed, and recently, it's been shown that you need to add another antiplatelet drug, like aspirin, but a little stronger. Why? Because these fresh stents inside the artery, they're made up of little mesh, little metallic meshes. The blood cells going by them think of that as a foreign body and want to stick there. So the chance of clotting is very high in a stent after you get it, unless you add a second antiplatelet medication. I've listed a few of them there, Plavix probably being the most common. Then there's Brilinta, Prasugrel, and another one, Effient. It doesn't matter. They are all valuable if added to aspirin, especially in the first 6 to 12 months. After 12 months, the likelihood of getting a clot in that stent falls off precipitously, largely because little scar tissue grows over the stent and covers it. And the blood no longer is exposed to the stent, which is now in the wall of the artery. So Plavix, Brilinta, Prasugrel are second drugs that are very important, especially in the first 6 to 12 months after getting a stent. After that, you can drop one of these two drugs, usually the Plavix or Brilinta because they cost a little money, and just take an aspirin. Now, beta blockers have also been shown over the years ago studies have been done, that beta blockers protect the heart if you have coronary artery disease. They protect the heart from getting heart attacks. How do they do that? beta blockers inhibit fast heart rates, and they inhibit high blood pressure, and they also cut back on stress hormones, all associated with heart attack and accelerated coronary artery disease. Almost every patient who has coronary artery disease is on some form of a beta blocker if they can tolerate it. Like any medications, there can be side effects. If so, drop the dose. If they can't tolerate it, then you can't tolerate it. But most will. Probably the most common beta blocker out there is metoprolol. Well, you might know it as toprol or Lopressor. But there are many other beta blockers that work as well. Now, we talked about statins over and over again. If you have coronary artery disease or, in fact, any vascular pathology, you must be on a statin to reduce that LDL. In fact, diabetes is such a big risk factor, even if you don't have a vascular event yet, if you're a diabetic, you should be on a statin irrespective of what your cholesterol is. Even if your cholesterol is normal, it's been shown to reduce future heart attacks and strokes. Now let's talk about our interventions for the patient who have significant blockages: stenting, bypass surgery. Stenting has been shown to reduce mortality, reduce the chance of dying if you present to the hospital with a certain type of heart attack. The type of heart attack that proceeds just as I explained before, a fresh blood clot closing the artery. How do we know if somebody with chest pain presenting to the hospital has that kind of a heart attack? We can tell by the EKG. There are certain classic changes on the EKG that will imply that there is a fresh occlusion of a major coronary artery. In that setting, we will take the person immediately to the Cardiac Catheterization Lab, since time is very important. Basically what we do is we go through either the leg, the groin area, the right groin, or the wrist, depending on the interventionalist or on your anatomy. We numb the skin over the artery underneath the skin there with Novocaine, just like when you go to a dentist. After that, the artery is poked. You wouldn't feel that because the area is numb. A little skinny wire is passed up through the arteries, going retrograde back to the heart, and with X-ray looking on, the arteries of the heart are found. The culprit artery that's causing the current problem is found. The wire is passed down that artery through the blockage, then over that wire from the leg or the wrist, another catheter is advanced, using the wire to guide it. On the end of that catheter is a balloon wrapped by a metal mesh stent. And metal is usually steel or cobalt. Now that metal mesh stent is advanced up, and when it's positioned right in the middle of that blockage, the balloon is then inflated, the stent expands, locks in place, the balloon is then deflated and removed. And you can see in the picture on the right, the artery is now open, the stent has pushed that soft blockage back up against the wall. Now stents are also used electively, as many of you may know, not with an acute heart attack. If we find that stress testing implies that there may be a blockage, a high-grade blockage in a very severe critical artery, or if patients come presenting with symptoms that we can control with medications that limit their quality of life, we would recommend cardiac catheterization or an angiogram to look at the arteries, and then if we find critically tight blockages in major arteries, we can electively put a stent in there too, and this has been shown to improve quality of life and reduce hospitalizations. This is an example of a 57-year-old woman who came to the office with a 1-week history of suddenly experiencing vague chest heaviness going into the left arm every time she does her daily walks. Never was there before, and it seems to be getting worse, coming earlier in her walking. Subsequent stress testing, non-invasive testing, revealed evidence that there probably was a high-grade blockage in a major coronary artery. On the left, you see the coronary angiogram, injection into that artery, that shows a 95 to 99% blockage. You can see that gap in the artery there. You could see it before, and the right, you can see it after. The stent is deployed, and the guide wire pulled out, and that artery looks entirely normal. This particular patient no longer had any symptoms, is back to her regular aerobic exercise. It is now 3 years later. Now, you may have blockages in many coronary arteries or in areas of the coronary artery that are difficult to get to with stenting. In that setting, we can provide surgery or coronary artery bypass grafting. Essentially what we do is we build a bridge around the blockages. The most common material for the bridge is a vein taken out of your leg because the veins are long and of similar size of the coronary arteries. A vein is removed from the leg, brought up to the chest. One end is sewn into the aorta, as you can see there on the right, and then the other end is sewn into the coronary artery in question beyond the blockages, so that blood can then go up and around the blockages and still feed the heart without any obstruction. Now, some blockages are treated with an artery to an artery, not a vein to an artery. Why? Because it turns out that artery to artery grafts last longer than vein grafts. Unfortunately, we do not have a lot of usable arteries in the body. Most arteries are important and need to stay where they are. But it turns out that inside your chest, inside the ribs there's a long artery called the internal mammary artery that goes right by and next to the biggest and most important artery that feeds the heart, the so-called left anterior descending artery. This is a very important artery, the artery that they call the widowmaker, because an unacceptably high number of people may not survive if that artery closes off. Well, it turns out that you can peel that artery off the inside the chest wall, just redirect it and plug it into the end of that left anterior descending artery, essentially going around the blockage and potentially saving a life if that artery was destined to close in the future. If you've had a heart attack or a coronary stent or any cardiac surgery, most insurances will cover 3 months of supervised and monitored cardiac rehabilitation. Why would they do that? You know insurance companies, they're businesses. They need to make money. Why do they pay for this? Because it has been shown that the people that do rehab or exercise regularly after a heart attack have a much less chance of returning to the hospital for a second event, second procedure, more surgery, which would incur tremendous expense to the insurance companies. So they are glad to pay for an exercise program after you've had the event. But the coverage is essentially only in the first 3 to 6 months can you enroll. Beyond that, they expect you to exercise on their own without the need for monitoring or supervision. Luckily, Good Sam has a state-of-the-art rehabilitation program right in the hospital that we try to get most people enrolled with after they leave the hospital with their intervention. So the whole cardiovascular continuum that we have involves these 3 tiers. The first is prevention. And by prevention, I mean giving community lectures, very much like the one you're listening to right now. We also have multiple outreach programs going into the community to improve the quality of medical care and educate the people. Secondly, we have treatment. The hospital has invested a lot of money in updating equipment, updating the rooms, such that now we have all the state-of-the-art equipment for managing vascular disease with coronary stenting and peripheral artery stenting, the cardiac surgery, bypass surgery, valve surgery, as well as state-of-the-art equipment managing dangerous cardiac rhythm disturbances, something which I have not talked about during this talk, but could be the subject of a future talk. And finally, in the end, we have a very organized approach to following up with the patient after they've left the hospital with their coronary event, whether it's a heart attack, stent, stroke, or just chest pain, again, through patient education and a very advanced, organized cardiac rehabilitation program right in the hospital. So in the end, yes, there is a lot we can do as physicians, but that's only half the game. The ultimate outcome is really up to you to handle your risk factors, essentially put away those risk factors for life. Anyway, this is where I'll end this talk. trying to give you this overview. And, you know, I look forward to you joining us again for future talks. Basically, now I just want to say that for more information, you can visit www.good-samaritan-hospital.org or call the number 631-376-4444. That's good-samaritan-hospital.org for the website. And I invite you to stay tuned for Good Samaritan's Facebook page for future virtual heart health lectures. I'm hoping to put a few more together before the end of the month. Thank you very much.